Good morning, everyone. It's 12 o'clock. I think we should start in time. This session is primarily on diabetic macular edema. You see, everybody manages diabetic macular edema in his own way. But since the time OCT has come and since the time injections have come and also the microvitreous surgery, these three things actually have redefined the way. Because when we were, into residency days, we used to have only angiography and lasers. That was all about diabetic retinopathy. And today, we are talking not only of stabilization of vision, we are not only talking of improvement of vision, but we are also talking about the improvement in the fundus picture, what we call as diabetic retinopathy severity scale also. And the patient's expectation has risen so much that all patients who get injections done or they want quick improvement, more improvement, and also durability, that they do not want to visit your clinic every month or so. And this duration and durability have assumed more importance now with the coming of anti-VEGF injections. You see, anti-VEGF, so many anti-VEGFs are now available. It began story with Macular, Avastin, then ranibizumab, then aflibercept, brolucimab, then faricimab is coming up in October this year. But believe me, DME still has unmet needs from the point of view of both patient as well as from the point of view of doctor. Because patient wants quick improvement, fast improvement for long duration, and surgeon is looking for an agent which can provide a long-term relief to the patient. And so many agents are now available. So in this workshop seminar today, we will try to highlight a couple of things. What best can be done? You see, ultimately, although diabetes is a multifactorial disease, it's not only hyperglycemia which is playing a role. There are so many other cytokines which are playing a role. The blood sugar, blood pressure, lipid levels, so many things are playing a role in diabetic retinopathy. So we have star speakers, Dr. Gopal Pillai, Dr. Venkatesh, then Dr. Devulal, Dr. Anuradha Mathi, Tyagi, Mudit Tyagi, and Ajay Dwani, who will share their experiences, how best should we do. So I'll request Dr. Gopal Pillai, who is, now a very senior ophthalmologist in Cochin, to tell us about what are Gopal unmet needs in DME.
Thank you very much, sir. Today I'll be speaking on understanding the medical unmet needs in diabetic macular edema. And this is my disclaimer. We would be browsing through the disease burden, and I'll be dividing the unmet needs from various perspectives. The most important perspective is the patient's perspective, and then the physician's perspective, and the healthcare system perspective, because healthcare is also what divides all those things. And then I'll summarize it. So what is a disease burden? All over the world, diabetes is a major problem, a menace. It is growing, right from North America to South and Central America to Middle East, Europe. Everywhere you see it is increasing, and Southeast Asia is no exception. And India also, there is a significant number. India houses about 1/5 of the world's diabetic population. And if you look at all the diabetics put together, about 40% of them will have some quantity of diabetic retinopathy. 17% may have proliferative diabetic retinopathy. 19% will have sight-threatening diabetic retinopathy. The diabetic macular edema is about 9.1%. The difference between proliferative diabetic retinopathy, which will potentially blind vision if not treated, versus diabetic macular edema, which reduces vision but will not create blindness. But what happens is, in that age where economy, financial gaining is important, your decrease of vision will actually put them out of the job. That is a major problem. But if you look at treatment in India, mean number of injections received is about 2 per year. That's a very, very low figure. You know why? 2/3 of patients drop out from therapy within 1 year. Most patients receive suboptimal treatment because many of them are paying from their own pockets and some of the patients do not have bystanders to come with them each time. And some people say that vision did not improve at all, and that is why should I re-inject? So these are the percentage of injection, but what you should know is approximately we will get only 2 injections per year for diabetic macular edema. Now, there was a survey by Indian retina specialists to understand the DME management perspectives, and it demonstrated that any fluid on OCT is a very important paramount factor for disease activity. Identifying importance of drying in the retina is very important, and injection frequency is a very important thing for non-compliance. 45% of the physicians felt the need to reduce the treatment burden and highlighted the need for more durability of treatment. Now, as I said, we will look at it from different perspectives. What is a patient's perspective? Always diabetic macular edema patients will have multiple problems. They have a lot of comorbidities, including stroke, cardiovascular disease, amputated neuropathy, retinopathy, nephropathy. All these are there, and he will have to spend time, effort, and money in all these problems. So, no wonder that the quality of life is very poor in these patients with diabetic macular edema. Patients and caregivers, they had to take time off the work schedule because injections won't stop. In protocol I of the drcr.net, they were talking about 9 injections in the first year, and you will require to follow up these patients every monthly, and that is why it will take a lot of the working time. About 4.5 hours is the time that they have to spend in the hospital. 53% of them are working patients, and 71% of them require a caregiver to come with them. And the caregiver will lose one day's salary or job, and because they are all employed, and those are some of the problems of the caregivers and the patients. Now, when you compare AMD with DME, in wet AMD patients, since we also counsel them that if you lose injections, you may lose vision very rapidly, their follow-ups are more better. Whereas in diabetic macular edema, a huge number of patients who do not show at all. And treatment compliance is DME is very low, even in the global, even in India. So that is one unmet need which is there from the patient side. So long waiting hours in the clinic, other problems like amputation or renal failure, all those things will contribute to barriers to follow up. So treatment compliance directly affects visual acuity gains in patients with DME. And we know that real world evidence shows poor visual outcomes with lesser number of injections. That is known all over the world. To summarize, patients have multiple comorbidities, and because of these and caregivers and their time and the perception that vision is not improving, they usually lose to follow up. Now, what is a physician's perspective? Physician basically identify reduction treatment burden as an unmet need. If we were able to treat somebody with lesser number of injection, which means that there is a long duration of action, then they feel that the patients will be more compliant. So they identified improved efficacy and safety as major unmet needs. So efficacy has to increase, durability has to increase, which will result in reduced number of injection. So that is the key to a physician's perspective. What about healthcare system? Healthcare system requires a management of comorbidities, monitoring these patients, increase healthcare utilization and treatment burden. You can see that significantly higher healthcare resource utilization in DME patients are there compared to non-DME patients. And so treatment of DME confers substantial burden on patients and healthcare systems because of frequent healthcare visits, frequent monitoring with OCT, and transportation assistance when people who have amputated foot or other problems, etc. So there are a lot of administrative challenges and clinical challenges in the health perspective, which we directly as ophthalmologists are not involved, but policymakers will be significantly involved there. So again, because of this multifactorial reason, there is a lot of problems with this. So disease burden, patient comorbidities, non-compliance and under-treatment, increased healthcare resource utilization, and suboptimal visual gains. These are the problems and unmet needs, and these obstacles, which are key obstacles, needs to be overcome. Thank you very much.
Thank you, Gopal, for dividing your talk into patient, doctor, and healthcare system perspective. But believe me, central to all this is the duration and durability. You can come and join me here. So, believe me, ultimately, we are all looking for increased duration of injection and durability. I'm not very sure whether physician wants a reduced treatment burden. Patient definitely wants a reduced treatment burden. Physician may want, patient to keep visiting the hospital. Although Gopal, through his 2 slides, said that physician ka unmet need also is the frequent visits. But believe me, it is more about the patient's quality, patient's relatives finding out that 4.5 hours time. They are more concerned. And the compliance is less primarily because of the comorbidities, because each diabetic has to visit at least 4 places: neuro, kidney, and then endocrinologist, and then eye care system also. So that is one reason all of us are looking for a method or a injection or something, so that this unmet need of the patient, I think primarily of the patient only, is fulfilled by reduced frequency of injection and reduced visits. Believe me, it is not only visit which matters, ultimately the whole financial system of the family suffers, because patient does not go alone, he has one relative along with him, then he has to travel, then get the investigation done, then treatment done. And if you multiply this by the number of visits in a year, this becomes a huge treatment burden. No, Gopal?
Absolutely, sir. So when efficacy increases, durability increases, and safety increases, there is a significant number of patients will find that coming to a doctor for treatment is very, very fruitful. Currently, what happens is that since the efficacy is a little lower, which means that each injection, the edema may reduce by about 10 percentage, or the vision may increase by maybe 1 letter, 2 letters, that the patient does not perceive as a very good result. So when the patient perceives it's a good result, there's an impetus for the patient to visit the physician again and again.
So may I ask Niaz, good friend of mine from Bangladesh, what is, you can be on the mic, yeah. Say it again. Eco.
Yeah, what's the question, sir?
Yeah. What we wanted to know from you is, what is your approach considering the reducing the treatment burden for the patient?
Yes, that is very important, reducing the treatment burden. But with also reducing treatment burden, the patient also can neglect coming back. So there has to be a compromise between the two. There has to be a communication between the patient and the center, so that we can call the patient in. But reducing treatment burden is obviously very important, because at the end, cost is a very big factor, and that sort of determines patient compliance as well.
No, key question, how do you counsel a patient? Suppose you have identified center involvement DME. What do you tell him, and how do you counsel him that you are giving an injection, or and how much frequency he will have to visit? What injection is your choice? What is your choice of injection in the first go?
Depending upon injection of now, as the newer drugs are coming in, we are finding that the newer drugs are more effective than the older drug. The amount of the macular edema reduces much quickly with the newer drugs like brolucizumab and faricimab than Avastin and all. So, but the thing is, there is a cost factor involved. So we have to individualize the patient's financial condition and what they can afford. So that is, I think, a very big factor, what the patient can afford, because in our country there is no health insurance and everything is out of pocket. So that is very, very important.
Yeah, this is a very important point you raised, because wherever there is health insurance, patient is not paying from his pocket, it does not matter much. But wherever patient has to pay a pocket, then what Gopal Pillai initiated as unmet needs from patient point of view, it becomes very, very significant. So Matthew, what is your take home about the choice? Thank you, Niaz. Can we have one floating mic? No, because we have so many injections now available. Are you looking at increased duration of action, or anything
I,
else?
I think we see both the parts, like it should be durable and it should be efficacious as well. So I think the afliversive and the newer anti-VEGF rolizumab comes in the first choice in treating DME, as an first line choice.
Okay, okay. I think with this small discussion, we will move on because we have only 1 hour. You see, most of us, check the vision of the patient in the first go. But what I would like Ramesh to tell us is that on OCT, you see, whenever a patient comes of DME, we check his vision, refraction, best corrected visual acuity, and then jump to OCT. Can OCT guide us, Ramesh, to treat this diabetic macular edema irrespective of the visual acuity? You see, poor vision, we always do it. But can OCT markers guide the physician in the management?
Uh, so thank you so much, Dr. Lalit Verma, and at the outset, thanks to AIOC and to the Novartis team for giving me this opportunity. So this is my disclaimer slide. So we all know that diabetic retinopathy is a vascular disease affecting the deep retinal capillaries. And when we look at the vascular changes which we see in diabetic retinopathy, it ranges from the earliest sign of microaneurysm formation to capillary leakage, and then formation of the non-perfusion areas, and eventually and finally leading to an edema and a neovascularization. So these vascular changes which you see on the clinical examination actually lead to structural changes in the retina, and that is what we try to figure out on the OCT. And these structural changes are mainly in the macular area. So when you look at an OCT in a patient with diabetic retinopathy and diabetic macular edema, this is the 10-step thing which I try to follow in every patient with DME. First, whether you want to know whether the disease or the macular edema is because of the diabetic retinopathy itself, identify the type of the macular edema, establish where the macular edema is present, also associate any disease manifestations, recognizing any disease manifestations to determine whether the severity of the leakage is high or low, then identify the effects of long-standing macular edema, look at the function of inflammation in DME, and identify whether there is macular ischemia and correlate them with serological markers, and then predict the visual prognosis. So when you look at the word biomarker basically means it is useful for diagnosis, measuring the disease progression, and predicting and monitoring the effects of therapeutic interventions. And it is of great importance for individualizing the treatment. So there are a number of biomarkers which are important, which will help you in diagnosis, treating the patient, and then also following up these patients. The OCT biomarkers are very important. Why? Because they are non-invasive, they provide near histological assessment, and they are important in assessing the functional outcomes as well. So you definitely want to know whether your patient who's going to have an improved vision based on the OCT markers or not. So these are the guidelines, with a number of international societies also recommending the use of OCT to assess, monitor, and evaluate the response to therapy in diabetic macular edema. So the first thing which we try to look on the OCT is whether it's a tractional or a non-tractional edema, and whether it is center involving or non-center involving or center sparing. So this is a very important flowchart which actually tells us that in a tractional macular edema, diabetic macular edema, you have the various components of the traction, and here the surgical treatment is the preference of choice. Whereas in non-tractional diabetic macular edema, you try to look at the different types of macular edema where you would consider medical therapy as the treatment of choice. So these are the few OCT images on the left side which shows you that the tractional component which is present, whereas on the right side you have the cystoid macular edema and a combination of cystoid and neurosensory detachment. The non-tractional edema is dependent on, now you need to look at the next step, whether it is center involving or center sparing. If it is center involving, the treatment would be with intravitreal injections, whereas if it is sparing the center, there could be a combination of laser photocoagulation which can be added to these cases. So these are images which show that the top one is the non-center involving diabetic macular edema, whereas the bottom one, it shows the presence of a cystoid macular edema. There are some fluid markers or OCT markers which determine whether there is increased leakage or increased activity, and one of the most important one is the measurement of the central macular thickness, the fluid activity, and the hard exudates. So when you look at the central macular thickness and the retinal fluid, you know that basically the fluid accumulation in diabetic macular edema happens because of the breakdown of the inner blood retinal barrier, and the presence of an increased central macular thickness means there is reduced visual signal transmission, and therefore, but it is not always is that when you have a high retinal thickness, the visual acuity is low in these cases. But there are a number of clinical trials and studies which take the central subfield thickness as one of the important OCT markers for measuring their outcomes of the study. Even the improvement in the visual acuity is documented by a reduction in the central retinal thickness with anti-VEGF therapy in most of the clinical studies. Even in this RESOLVE study which you can see with the reduction in the macular thickness, there is an improvement in the ETDRS letters in these cases. The second important point is the presence of fluid in different compartments, the intraretinal and the subretinal fluid. And there is a difference between the fluid in a diabetic macular edema case versus a AMD case. In a diabetic macular edema, it's primarily because of the breakdown of the inner blood retinal barrier, whereas in an AMD case or a neovascular AMD case, it's because of the damage to the outer blood retinal barrier. The intraretinal and the subretinal fluid, they are all associated with disease activity, but the intraretinal fluid is more prevalent due to the breakdown of the inner blood retinal barrier. So you can see that even in all these post-hoc analysis with the protocol T, the Vivid Vista and the Apollon studies, they clearly showed that the IRF is more commonly present than the SRF, but both the fluids component, they indicate activity. Both the presence of fluid in both the compartments, the intraretinal fluid and the subretinal fluid, they are associated with reduced retinal sensitivity and reduced function. And you can see that as the size of the intraretinal fluid or the large cyst keeps increasing and that there is a development of the subretinal fluid, the retinal sensitivity keeps dropping further and further down. So both intraretinal fluid and subretinal fluid are associated with a poor best corrected visual acuity. So in DME, all the fluid is considered to be pathological, and it's not like an AMD case where you can leave a cushion of SRF in a DME case. You cannot do that. Now let's look at the other factors which are suggestive of activity. This is the presence of hard exudation. These are lipid-laden macrophages or lipoproteinaceous material which is associated with fibrin and fibrinogen. And you have this another important paper which we published recently, which is suggestive of the intracystic hyperreflective material, which is a combination of heme, exudates and fibrin which is present there. So this is one of the photographs of the OCTs which is showing how the patient started with, then there's development of a cystoid space with a hyperreflective material. You start treating the fluid cavity. The fluid cavity reduces, but the hyperreflective material resolves over a period of time. So this is the publication which I was talking about, where we talked about the intracystic hyperreflective material in cystine involving diabetic macular edema. There are some important OCT biomarkers which talk about chronicity, and one of them is the bridging retinal processes which you see on the OCT, which indicates that there is a stretch on the bipolar cells, and therefore there is a reduced retinal sensitivity. And another important finding is the presence of a pearl necklace sign, where you can see all the hard exudates getting accumulated along the wall of the cyst. Very important marker which we talk about is the presence of hyperreflective foci, and these hyperreflective foci are basically because of the breakdown in the inner blood retinal barrier, and there are multiple theories which have been postulated for this. This can be extravasated lipoproteins, activated microglial cells, or even migrated RPE cells. Their size is less than 30 microns, they do not cause shadowing, and they are present from the inner to the outer retinal layers. They signify inflammatory markers, they respond more better to corticosteroids, and the presence of the hyperreflective foci in higher numbers suggests that there is a more likelihood of recurrences of diabetic macular edema to develop. So when you look at this comparison between the hyperreflective foci and the hard exudates, there is a number of differences ranging right from the size, the location, shadowing, and the reflectivity which you see between these two entities. Now, there is another recent publication from our end which we spoke about the cholesterolization of the RPE, where we called it as the onion ring sign. You can see this linear hyperreflective crystalline deposits which are present both in the inner retinal layers and in the RPE level, and this is one of the markers which suggests that there is a conversion of the hard exudates to cholesterol, and if they are present at the RPE level, they will lead to permanent destruction in the visual acuity. So there are a few OCT markers which talk about poor vision. One is the presence of the drill, where there is parallelism which is lost in the inner retinal layers, and they signify that there is a poor vision which is present, especially especially if the drill is present within the 1 millimeter central retinal zone. And this is all because of the neural retinal disorganization which happens in patients with resolved, which is a marker of visual acuity, especially in cases of recurrent macular edema. So you can see that the drill, this is the presence where there is a edema, macular edema and the drill, but the drill is basically has to be diagnosed when the macular edema is resolved, where you see that there is no parallelism which is present between these layers. Now, the drill is not specific for DR, and when you look at the drill in correlation with the OCT angiography, the presence of the drill indicates that these are the areas where the capillary dropouts are present, and that is why there is a disorganization on the retinal layers on structural OCT. The other important prognosticating find is the presence of the ELM ellipsoid zone discontinuity. So you can very clearly see with the white arrow that there is a destruction or a discontinuity which is present in the outer retinal layers, which is suggestive of a poor prognosis. So when you look at the factors which indicate poor prognosis, these include drill, which leads to mild to moderate vision loss, which signifies macular ischemia, the outer retinal layer disintegrity, which indicates that there is a damage to the photoreceptor layers, and the RP, which indicates there is a probable severe visual loss, and the recently published one where we called as the hyperreflective crystalline deposits, which if present at the fovea will lead to severe vision loss. So this is a worksheet which we are working upon, trying to answer these 10 points on the OCT and then trying to establish what would be the visual prognosis in these patients, what would be the treatment options which we should consider, which intravitreal agent should be given, what regimen we should be following, whether it should be monthly dosing, PRN dosing, treat and extend, and what could be the probable or predicted visual outcome which is seen in these cases. So this is what I wanted to say. It's not always visual acuity. The visual acuity may be a starting force for guiding your treatment, but eventually it is the OCT biomarkers which will determine whether you need to continue treatment, stop the treatment, and predict the visual acuity or visual prognosis in these patients. Thank you very much.
Thank you, Ramesh, for highlighting the importance of OCT biomarkers. So one direct question is, do you treat based on visual acuity or OCT biomarker? Do you treat based on OCT biomarkers or visual acuity or both?
So my initial treatment is basically
Can I request,
so the initial treatment is based on the OCT. From the OCT itself, we will come to know what is the traction, non-traction. Then you decide
No,
whether.
those things are very clear. You see, fractional, center involving, non-center involving, I think. But issue is which OCD biomarker, or may I ask you if patient has drill, and if patient has disruption of ellipsoid zone.
So
apart from giving a poor prognosis, do you treat them still?
No, not really. The hyperreflective foci is one additional thing which probably I will try to look into, which will suggest that there is inflammation or no inflammation.
Any of the OCD biomarker tells you that this patient should be treated with what agent?
Yeah. So the
I'm talking of center involving DME non-tractional. Any OCD biomarker tells you that what agent should be used. I'm sorry, this echo I can't help, but there is because of the increased size of the hall. But my question is, any of the OCD biomarker in a non-tractional center involving macular edema, does it guide you that you should select this agent versus this agent?
So if there is a presence of a cystoid edema with a neurosensory detachment, probably we all tend to go towards steroids because we all feel that there is increased activity which is present and inflammation which is causing the neurosensory detachment, or even a very potent anti-VEGF agent, which would probably be an aflibercept or a brolucizumab in those cases.
Okay, anybody has any point or question which is what Dr. Ramesh has said, which is different than the others? No, I agree, OCT biomarkers have played more and more role, but even if it is a traction macular edema, sometimes we may, give injection. It's not that once you find OCT, this is a traction and you straight away jump for surgery.
No, if it is not center involved, means if the traction is away from the center and not involving the center, and if the tractions are not very vascular, then in those cases anti-VEGF we can avoid and then still go ahead and treat them with steroids.
Okay, thank you, Ramesh. Time is not on our side because we have to cover 3-4 more talks, and now we have none else than giant from the east, Anuradha Mathi, to tell us about breaking the clinical dilemmas. You see, what Mathi is going to tell us is whether we should treat DME aggressively or maybe, PRN kind of regimen can be done, SOS kind of management can be done. Because in AMD, we all understand that, we have to give monthly injections. What about DME, Maiti? You want initial aggressive treatment or you want PRN?
Thank you, sir. Well, I will be speaking on the breaking the clinical dilemmas in DME management. Should we treat early and aggressively? So we are not going into the disease burden in India. We are all aware that diabetic retinopathy, the PTR and the DME causes the loss of vision in the working age group. And this is the evolution pattern which started from no treatment to what we are speaking right at this moment is optimizing treatment. Now, a significant proportion of these DME eyes continue to experience persistent fluid despite the treatment of anti-VEGF therapy. We have seen in the protocol I post-hoc analysis, it can actually give us a cumulative probability of this chronic persistent macular edema after 6 months of treatment. That is at least 4 injections. At the end of 12 months, there will be 81% of the patient having persistent fluid, 56% at the end of 2 years, and at the end of 3 years, 40% of the patients. So there's a large number of patients who do have this persistent macular edema. And we also know that the chronic macular edema leads to irreversible damage of the macula and permanent visual loss. Persistent macular edema results in lower visual gains in DME, and longer duration of this persistence of macular edema results in poorer visual gain in DME. So, as sir was asking this questions, whether we should treat early and aggressively, as we can see in this rise and ride pull trial, this is where one arm got anti-VEGF throughout till 24 months, and the other was a sham control treatment where the treatment was not, only sham treatment was given. And at the end of 2 years, there was a crossover. And what was the results? If you see, the arm which was getting anti-VEGF gained 12.4 letters, whereas the arm where the crossover was done after 24 months had only 4.5 letter gain. So if we delay the treatment by 2 years, we are actually losing this visual gain at the end of 3 years. Now, early treatment with ranibizumab provides rapid visual gain sustained for up to 5 years. This we have seen in the extension of the restore, that is after the gain which was obtained at 12 months, that is 7.9 letters, maintained through 3 years with the treatment, and same we saw in the protocol I 5 years trial. Now, early initiation of the treatment leads to approximately 76% of the patient maintaining visual acuity of greater than 69 letters at month 12. This is what was also mentioned by Dr. Lalit. The early treatment with ranibizumab led to greater than 75% of the patient achieving more than 2-step dear diabetic retinopathy improvement by month 12. That is based on the diabetic retinopathy severity scales. That is, with the aggressive early treatment, we can bring back the advanced stages of diabetic retinopathy based on the score of almost greater than 2 steps, which is very important and we should keep in mind. So, to summarize, diabetic retinopathy is the leading cause of blindness. We are all aware of it, especially with the working age group. Chronic macular edema can lead to irreversible damage of the macula and permanent visual loss. The DME patient with the persistent fluid have lower visual gain compared with those which achieve an early resolution. So early intensification in DME is very important to prevent this avoidable visual loss and treat rapid and to get a sustainable visual acuity gain. And lastly, this early treatment with ranibizumab lead to greater than 75% of the patient which achieves greater than 2-step diabetic retinopathy improvement by the end of 12 months. Little bit on the experience of ranibizumab in DME. This was one of the first cases where we started this new molecule. This patient had undergone 4 injection of ranibizumab, 2 dex implant, but it was a chronic macular edema. As you can see, the vision was 3/60. So we thought we have tried everything. Let's start this new molecule also. And you can see with a single injection, actually the patient was symptomatically better from 3 by 60 to 660, as it was a chronic macular edema. Nothing much was there to increase in vision, but still there was slight bit of increase in vision. This is the other eye. So we started with the refractory case. This is one of the refractory case where it improved from 624 to 612. This is another, this is after 3 injection of ranibizumab. Here there was a 2-line improvement. So initially we tried in the refractory cases, we got a good result. So thought of using it in a treatment naive patient. This is after a single dose of brolizumab in DME. The vision improvement was 660 to 624, quite a remarkable improvement with anatomical improvement in the OCT. This is in the other eye. This is also a similar case from 660 to, after 2 injections of brolizumab, it improved to 618. And this is the last case where the vision improved from 660 to 618. So the take-home message about this new molecule in the treatment of DME, definitely it has showed a better drying effect, whether it was an intraretinal fluid, subretinal fluid, or a central macular thickness. It was effective in both naive and persistent or refractory cases, although the effect was more significant in the treatment naive patients. Luckily, there was no patients with postoperative inflammatory signs, but definitely time will say, because it has just been approved for DME, whether it will be the safest or the most effective medicine in the treatment of DME. Thank you.
Thank you, Mati. I think the answer is very clear. Early treatment is definitely required. There's no doubt about that. That why you should allow the fluid to accumulate. There's no doubt in anybody's mind. But question was how much aggressive you have to show. How much aggression means every few months you want to treat, or you want to call the patient. That is the
So
key.
if the finance was not a problem, then I would have given a
Forget
loading
about
dose
finance.
of 3 to 4 injections.
We should not talk about finance at all.
So then in an ideal scenario, I would counsel my patients to get at least 3 to 4 injection as a loading dose, so that we can treat early and as well as aggressively.
Yeah, I think this concept is building up, Gopal. You have to be early, there is no doubt, but aggression also has to be shown, because if you allow the fluid to come back, and as the Ramesh also said and Mehti also said, believe me, all fluid is bad. God gave us a dry retina. God did not give us, a wet kind of, some fluids are tolerable, some fluids are, that SRF is good and IRF is bad. I personally believe all fluids are bad, and all attempts should be made to dry this fluid. And if you have agents which are powerful, like we have brolucimab, they should be tried. And the last question was about the usage of this new molecule as in a treatment naive patient. You see, all of us use these new molecules in refractory patients. But slowly, as this label has increased now, brolucimab is now approved for DME also. Is your confidence increasing that you will not use only in refractory, but in naive
naive
also?
as well.
You see, everybody jumps to brolucimab once there is no response. Like you said, 81% and then 56%, 40% have persistent fluid. So we try anti-VEGF, usual anti-VEGF, and then shift in refractory. So what is your confidence level today to start?
Start with this new molecule.
Same one. No, brolucimab.
Yeah, as I was mentioning in my cases, in the refractory cases, they are responding anatomically, but functionally there is a limitation, because nothing much to improve as far as the visual acuity gain is concerned. So why not in a treatment naive? Because the only concern in the treatment naive was the inflammation. So now that we have been using for 2.5 years, we can easily convince the patient for an primary therapy in a naive patient.
You see, this fear of inflammation, I think, has been overhyped. Frankly speaking, the experience in India is totally different from experience in the West. Although label says around 4%, believe me, in this part of the world, and you have experience, Debulal has a lot of experience, and so many other people, we haven't seen so much of inflammation. Niyaz or anybody else, Mudit, your take on inflammation after brolucimab? Debilal, you can be ready by that time.
Yeah, so surprisingly, compared to what has been reported earlier, you're right, sir. We have not seen that significant inflammation even in our diabetic patients. And I have seen it in two patients. One was an AMD patient, the one diabetic. The diabetic patient actually could be just managed by the help of topical steroids, and even there we were not very
Two
sure.
out of how many?
Or maybe 60, 70 patients till
Yeah,
now.
that's what I was coming to, the percentage of inflammation. In fact,
Yeah.
honestly speaking, we haven't seen it all.
Exactly.
But inflammation may happen if you know use it very often.
Yeah. And in the second case, actually, which we had seen, I'll show that case in my talk. There was a patient who had also taken a Covishield vaccine 2 weeks earlier. So I'm not very sure if we can attribute it actually to brolucizumab. But the good part was that we kept the patient on follow-up, and the inflammation went away with just topical steroid. And subsequently, she's received 2 more injections of brolucizumab and has not developed inflammation.
Yeah, that's another learning point, that even if patient has shown, does not necessarily mean that you know you should stop dosing.
Yeah.
So thanks, Maiti, for
Thank you, sir.
emphasizing this point, that early aggression has to be shown for long-term good visual benefit. Gopal, any point you want?
No, sir. Let's move to the next talk.
Okay, thanks. Now we move on to one of the most experienced person who will tell us about new frontiers, Debular.
Sir, thank you for this opportunity, sir. And today, probably we don't need to tell each other that anti-VEGFs are the preferred first line of treatment as far as center involving diabetic macular edema goes. But let's look at this case. So this is a lady, 56-year-old, lady, and she is fairly controlled with like her diabetes. And this is her list of injections: 20 ranibizumabs, 3 bevacizumabs, 2 aflibercepts. And because these were not working, so I jumped the gun and did a IVTA. And lo and behold, we had the raised IOP, and thankfully, God saved me, and it was controllable. But you know, what is the background story? This patient has been with us for since 2014, and up to 2019, she has had 62 visits. This is a patient who's actually very compliant, and she has had 28 injection visits. So just imagine the predicament of the patient. So is this unusual? Not really, because if you look at the studies published with Boreal study, even with 7.6 mean injections, there was a treatment failure of 24%. And if you look across, anti-VEGFs, then the rates are even higher, up to 40% non-response. And this stems from the fact that many of the patients are partial, poor, or non-responders to anti-VEGF therapy. So we have, unmet needs, as has been amplified. We need better drugs, more durable drugs, and difficult to treat phenotypes need drugs that are different. So one very important thing is we mostly go PRN in our country, believe it or not, or agree it or not. And a lot of these patients get 3 injections at the most, maybe even less. And Luminous study says 50% maybe get 4 or less injections, 60% up to 5 injections. So that's not going to do good if you are looking at some improvement of vision. It might maintain vision. So you need 5 to 7 injections of ranibizumab if you are to treat these patients. India is a special case. As in the developing world, non-affordability is a big factor. Multiple number of injections, multiple times coming to the hospital is very difficult. And as I mentioned, PRN regimen is something that we vouch for. So we need new frontiers in the treatment of DME. And one of the new things that have come up, just like sir mentioned, was brolucizumab. It's a small molecule. You can pump in more drug, as also faricimab and PDS with ranibizumab. Now these two are not yet available in the country and probably be available soon. But going back to our index patient, what happened post this raised IOP? We offered her brolucizumab. It was off-label at that point in time, and this is how the patient behaved over the next 3 months with just 1 injection. There was improvement in the anatomical characteristics. There was some degenerative looking cysts. We held back till 3 months, and this is what happened at 4 months. So there was intraretinal fluid distinctly coming back, and this is when we injected her with the next injection. The story since then, long story short, 8 injections of brolucizumab over 2 years from time of shifting over to brolucizumab. So this could be something that could dry up the retina better, and like sir mentioned, all fluid may be something that's not really good for the retina. So is it justifiable? Well, the studies do say it's justifiable, because brolucizumab patients treated with brolucizumab have lesser IRF and SRF, as per studies. And visual acuity wise, it is pretty much similar to aflibercept, non-inferior to aflibercept. So also the central subfill thickness, but fluid drying is something that's better with probably brolucizumab. Sir brought up the topic of adverse events, and with Kestrel and Kite, it's even Stevens as far as brolucizumab and aflibercept is concerned. 1% versus 2% for brolucizumab versus aflibercept, and this is 2% versus 1.7%. So pretty much similar. And so I'd like to share a couple of our publications. So this is part of the series of that 3 cases. So this is a patient who received 11 ranibizumab injections, a very strong family history of diabetic, father going blind, 37-year-old teacher, and I didn't have the guts to inject steroids with him, offered him aflibercept. But interestingly, this is a patient who actually is with the West Bengal government schools and has the patient support scheme from the government. So 1 month post brolucizumab, this is what happened. There was this reduction in the fluid. And this is 3 months post brolucizumab for further reduction, and what looked like a degenerative cyst reduced further. Some improvement of vision as far as the patient was concerned. There's this FAZ distortion, and this is 4 months on. The retina still looks dry. So these 3 cases showed a similar pattern of the activity of the drug lasting for up to 16 weeks. And basically, if you look at the back end story, 8 injections in the first patients, 9 in the second patient, and 8 injections in the third patient over a period of 2 years. So you have a drug that's probably more durable than what we have as of now. The other publication that we had actually was interesting. This is 13 patients who had a mean of 15 injections of different anti-VEGFs and steroids, and this is something I thought was important. If you look here at 4 weeks, there's a significant improvement as far as the visual acuity is concerned, and this is something that lasts out till 12 weeks, and beyond that it starts to wane off, as also the central subfill thickness. Up to 12 weeks, it is statistically significant, and then it wanes off. So you have to find a sweet spot maybe somewhere here to re-inject these patients. And we didn't have any inflammation in these patients, and up to 6 months, the mean number of injections required was just over 2. So basically, brolucizumab is effective in recalcitrant DME. I'd like to share a couple of cases to end in naive situations. This is a non-center involving DME that we did laser in both the eyes, and post 2 months of laser, this is how the retina looked like. Again, a West Bengal health scheme patient, and so we injected brolucizumab with oral statins, and this is how the retina looked after 3 months. Some improvement in vision, and actually there seems to be some reversal of the drill. I'm not sure about that, but there seems to be a reversal. Now let's look at this patient. This is the last one. Retina looks okay-ish as far as the fundus is concerned. Vision is not too great, 618 versus 624. And this is how the OCT pictures, looked at presentation. So we offered him a bouquet of, all agents. And again, this was a West Bengal health scheme patient. And this is at 3 months, the retina looks better. And the OCT, of course, looks better. And the retina is still dry at 3 months. So brolucizumab is effective in treatment of DME, it seems, and there may be, it's something that's effective in reducing the treatment burden because you need lesser number of drugs, and tackling DME, as sir mentioned, more aggressively with a more potent agent could be beneficial. So that's all. And I would like to take this opportunity to welcome you all to the next AIOC at Kolkata.
Debulal, excellent talk as usual. Really enjoy your talks. But one thing I did not like was maybe it is effective for reducing treatment burden. What is the shyness?
Sorry, sir?
Why? No, what you last slide, your slide said it may be. Can you put the last slide?
Yes, sir.
I may reduce. You see, first lane is perfectly okay. Brolucizumab is effective. No doubt about that. Why are you saying may be effective?
Sir,
you see, two
yes,
things, because all through your talk, you said it is better drying effect.
Sir.
Secondly, you also emphasized 12-week interval.
Sir.
Then why are you shy to say it may be?
Sir,
why are you shy?
Yes, sir. Specifically because I have a published evidence of only 15 cases. But
so if I was you, I would be bold enough to say that here is an agent which can reduce your treatment burden.
Sir, thank you, sir.
Thank you for
thank
very
you, sir.
nice illustrations.
Thank you, sir.
So, thank you. Excellent messages conveyed. That is the beauty of Debulal. Now we'll have Mudit to tell us about the real world experiences about brolucimab. You see, the thing is, if you have a better drying agent and if the duration also is good, Farsimab is on its way. Farsimab will land in this country around October and November. And till such time, therefore, I told Debular, why should be shyness be there? So let's hear from this young man from LV Prasad.
All right. So good afternoon, and first of all, let me thank AIOC, the scientific committee, and the chair of this session, Dr. Lalit Verma, for giving me the chance to speak about our experience with brolucizumab. Now, I have no other financial disclosures. Now, before I go ahead, we already know that protocol T, which was the first comparison or study which compared head-to-head DME with three anti-VEGF agents, which compared aflibercept, bevacizumab, and rituximab, showed us basically that if you look at eyes which had a good visual acuity to begin with, all of the three compared well to each other. But eyes with a visual acuity of 20/50 or worse, it was there that aflibercept scored better and had a better effect in terms of improvement in retinal structure as well as in terms of improvement in visual acuity. What we also know is that in spite of it, in all of those studies, and there was an analysis where they tried to analyze the eyes which had a persistent macular edema even after 2 years of treatment, and 29% of eyes with aflibercept, more than 50% of eyes with bevacizumab, and more than 30% something with ranibizumab also had a persisting DME. Now, what do you mean by that? There is no specific definite accepted definition of recalcitrant or persistent DME otherwise. But what we do know is that an inadequate response to a combination of laser, steroids, or any anti-VEGF therapy, and refractive DME was defined as central retinal thickness greater than 300 microns or a reduction less than 10% after at least 3 prior anti-VEGF injections. Why do we get this in our practice? Why do we have patients who may have a recalcitrant DME in spite of all that we are treating them with? And there are no specific single answer. There are multiple reasons for that. You may initially actually have just a ceiling effect. The patient had a good visual acuity to begin with. Inadequate treatment, and by that I mean either not long enough or not often enough. And we have just had previous talks which have showed, where Dr. Anirudh Maiti also showed the importance of treating these patients aggressively from initial inset. Systemic factors, we know diabetes is a complex disease. It's not just ocular features, but glycemic control, hypertension, all of them come into play. Non-VEGF pathways like inflammatory mediators, delay in treatment response, and then structural changes. Dr. Ramesh Venkatesh very nicely showed the OCT biomarkers which can have an importance in prognostication in cases of DME and post-vitrectomized eyes. So what were we doing for these patients till now? We either did focal laser, switched to other anti-VEGF agent, or resorted to intravitreal steroids like dexamethasone implant or fluocinolone acetonide implant, something which we don't have access to at this point of time. But now we have one more molecule, which is a single chain antibody fragment. We have already seen multiple cases, and I'll be showing you some more cases of it. And why does this probably work better than other conventional anti-VEGF agents that we have had till now? And the reason is that it has got a more VEGF binding ability per volume. The molecular weight is the lowest, 26 kilodalton. It has got a higher affinity for VEGF-A, and it has got a more effective tissue penetration. Now, all of those basically translate into a much better outcome in a lot of our patients. And there are studies which have shown that it penetrates the retina rapidly, and these are preclinical studies which showed the outcomes over here. Now, the Kestrel and Kite studies which compared brolucizumab with aflibercept showed that in both these studies, brolucizumab did score better in terms of duration of treatment-free interval as well as in terms of improvement in vision and reduction in retinal thickness in terms of intra and subretinal fluid. Now, one of the apprehensions which we have always had till now probably, and we just had a discussion just 2 minutes back prior to this talk about this apprehension regarding inflammation which was happening, but we are not seeing that in our patients as much as what we feared earlier. So now comes what can we do for these cases. We already spoke of focal laser switching, but now like I said, we have another agent called brolucizumab, and we explored this in our recalcitrant DME. Now Dr. Lalit Verma sir just said about our probable use of this now in even treatment naive patients. Honestly, till now I have not tried it in my treatment naive patients, but I have tried it in a lot of my recalcitrant cases, and we have had some surprisingly good outcomes in a lot of these patients. Let me show you a few of these. So this was one patient who had presented to us a visual acuity of 2120 and 2080 in the right and the left eye, had received 4 injections of bevacizumab earlier, was treated with every possible conceivable agent that we have at our armamentarium in terms of micropulse laser, 3 injections of Dex implant in right eye, 2 in the left eye, modified grid laser, IVTA, 1 injection of zivaflibercept also. But since the patient was not improving, we resorted to the use of intravitreal brolucizumab. And look at the left eye. The left eye edema is resolved significantly. Right eye initially was still persisting, but post 4 injections, this is how the visual acuity is. It is improved to 20/80. There were no adverse events. It's at this stage that the patient refused to take further injections, but the visual acuity improved for the first time over years in this patient. Another patient, again, history of multiple injections of ranibizumab and dexamethasone implant, and subsequently post injections over there. This is how the patient visual acuity was improving to 20/30 in the right eye, 20/60 in the left eye, treated with 3 injections of brolucizumab, and this is how the final visual acuity was 20/30 in the right eye. Left eye, which also had structural changes, hard exudates, subfoveal exudates over here, hyperreflective dots, also improved to 20/40, and that was possibly the best vision that we have been able to achieve for this patient, in spite of the patient being on treatment for the last 4 years with us. Patient underwent a phacoemulsification in the left eye. The edema recurred in the left eye again, but post injection subsequently now the patient maintains a visual acuity of 20/30 and 6 in both the eyes. And this is the third case which I actually want to show. This was a school teacher who had 2500 vision in the left eye, ischemic macula, unlikely to improve, but the right eye had a visual acuity of 20/60. This was how the right eye was initially after 1 injection. Subsequently, the structural changes started regressing. The fluid went away, reduced from what it was earlier. The patient was lost to follow for a few months, came back, we re-injected, and post 6 months the patient was maintaining a visual acuity of 20/30. This is the first time that the patient had a visual acuity of 20/30 in the right eye, which is the better eye of this patient. 9 months again, visual acuity maintained. The patient came back with worsening after 12 months, or that is 3 more months later, with a visual acuity of 20/200, got the 4th injection, and over here again the visual acuity improved to 20/30, maintained at 20/30 another few months, comes back with a recurrence at 15 months, that is 4 months after the injection. At this stage, this is the case I was discussing about. Patient comes back with increased AC inflammation. No hypopion, but increased AC inflammation. And like I said, this patient had a history of having taken a Covishield vaccine 2 weeks back. We have had patients who had a AC inflammation post Covishield vaccination also, so we could not attribute it or pinpoint it to one of the two. However, we kept the patient under observation. The patient's inflammation resolved with just topical steroids. Patient now maintains a visual acuity of 20/30, has had 1 more injection, and now even after that, at this point of time, the patient maintains a visual acuity of 20/25. So this is how brolucizumab is working in a lot of our patients. It offers a ray of hope in recalcitrant DME. And I think as retina specialists, we are now living in very exciting times where we are getting more and more newer molecules. Faricimab is on the horizon. Same holds true for the increased dose regimen of aflibercept. And I think we now have multiple options of taking care of our patients and taking better care of our patients. Thank you so much.
For showing excellent cases, but for the want of time, I think we will have a brief discussion after, Dudani's presentation. Yes, Dudani.
Yeah, thanks. Thank you so much for your kind invite. I'll be speaking to you about impact of brolucizumab on fluid resolution in DME, real world experience. Can I have my slides, please? Yeah, thank you. So this was discussed, so I'll skip this slide that brolucizumab
Dudani,
was...
can you come to cases directly?
Yes. So basically what we have is, this is just one slide. I wanted to say that what I call as rebellious rebels of diabetic macular edema, they don't behave naturally. You expect the unexpected. Surely you would have seen such patients where the DME doesn't respond to your treatment and you find that you have got an orange when you look for an apple. And most important, I feel in our subset of patients, we have patients who are like rebel patients. The disease is not rebelling, but the patient is rebelling by not coming. He's a young gentleman of 40 who is working, as Gopal said, and he doesn't have time to leave his job and come. So ensuring compliance is the key in controlling the progression of irreversible loss in this. And we know that this is a multifactorial disorder. So let's jump into my cases. So this is a 75-year-old Sindhi gentleman who was totally uncontrolled diabetic with a very high HbA1c. He was a one-eyed patient. He had received some laser and some injections elsewhere. The right eye had developed foveal atrophy, and this is how he came to me in 2017. So we were treating this patient. He had all the signs of chronic CME with drill and everything. So this is a resolution post dexamethasone intravitreal implant at 2 months. The fovea came back with this single owl eye sort of feature here, which you could see here. This recurred again at 4 months, and then we again injected dexamethasone implant because he had already been lasered well enough, and he had received anti-VEGF. His vision improved to 618 at 3 months again after treatment. Then there was again delay, and we have faced those cases where there's a COVID lockdown and the patient doesn't follow up, and he came back with this severe edema here. And with the post-COVID effect, he had an IOP of 40, so there was no question of giving him Ozurdex, and he had this chronic CME, and his vision had gone down to 4 meters in this only eye which he was seeing. So we decided to give him brolucizumab, and this is the post-resolution of brolucizumab. At 30 days, he recovered his vision to 6/60. This is the second case. I'll just share with you 2 more cases. Just give me indulgence for 5 minutes, 2 minutes more. So this is basically a 75-year-old Malayali gentleman who was a diabetic for 26 years, pseudophakic, and this is how his eye looked. Both eyes DME. So we gave him Ozurdex implant. So the right eye didn't respond well and the left eye responded very well. We switched to brolucizumab because as he was traveling out of country, so we suggested that we'll switch to brolucizumab after doing the Ozurdex and laser. And this is the response we got at 20 days. The left eye resolved completely and the right eye also is showing resolution. So the advantage is he's coming back after 3 months, so we can have a prolonged effect of this drug in his eye. This is the last patient who was a 60-year-old DME patient with PDR glaucoma. We had done ranibizumab laser, then we did a bevacizumab switch. So this is how it went on. You can see this case. Both eyes he had DME, which responded to ranibizumab laser. His vision also improved to 618. The left eye was the one which was resistant. Yeah.
No screen is coming.
Okay, fine. Thank you.
So I appreciate the chairman scientific committee's dictum that we have to finish in time. We just conclude this session by only 2 lines, which I would say that there are unmet needs in DME. Secondly, early aggressive treatment is the need of the hour. And third is don't be afraid of using brolucizumab for the fear of inflammation. Thank you, Gopal, and thank you the audience for bearing with us. Thank you so much. And thank all the speakers for showing wonderful cases.